Welcome everybody to the Mold Pros monthly webinar series. I'm really excited about this month's speaker, Jessica Perley. I've known her for like 7 years, and I'll tell you that there's not anybody else that I'm more excited about introducing here. We've worked together for a long time and picking each other's brains, shooting off ideas. And I'll tell you, there's probably nobody on this planet that understands the Great Plains' oat better than she does. If anybody has a question on like what a particular marker means, I would ask her. So today she's gonna be talking about the gut-brain connection and how different toxins could affect that connection, how different, how the gut and the brain interact. So this is this is gonna be a great talk. I'm really excited about it. So I'm just gonna step out of the way and let Jessica take control. Go for it, Jess.
Thanks, Matt. Yes, we have known each other a really long time. In fact, we were just talking about that. And when Matt asked me to do this talk, he said, do whatever you want. And I said gut-brain connection. And the reason why is because two reasons. I'm finding that people on the Western side of medicine, my colleagues on the Western side, are oftentimes completely unaware of a gut-brain connection, completely unaware, which is dumbfounding to me. I almost don't even know where to start. So I think this is kind of nice to have a few talking points to be having with our patients and with our colleagues that don't know as much about this. The other reason is that on the kind of the more integrative functional side of things, I find that there's some misnomers out there and that people kind of believe it so blindly without really knowing what that data really says. And that's something for good reason. The data is always evolving, the data is limited. But I just thought, this is something that I've been wanting to talk about for a while. And I haven't done a literature review in like 5 years. And so it's time for another lit review, right? So here's kind of briefly my overview. I want to just kind of review our patient population in brief. I think that's an important piece to this, and you'll see why. I'm going to kind of just talk about the current literature, which I have 65 pieces of data that I used in this lit review. So I encourage you to go back and look at those if there's anything of interest to you. Common misunderstandings and clinical mishaps, and then just kind of a few recommendations for care. Nothing too heavy, just kind of keep it kind of light tonight, hopefully. But what I want to start off with is just kind of talking about the trouble with symptoms. So our primary patient population here in kind of integrative functional medicine are patients who are sick and no one knows why, right? So in the literature, it's termed medically unexplained symptoms, disease, or illness, so MUSD or I. And essentially the problem is that we are not sure which of these domains their symptoms are really coming from, right? So you can have your environmental factors like inflammation, like toxins, like pathogens that are influencing our neurological system and our gut system. And those are the things that's actually kind of easy, right? That's a little bit easier for us to unpack. But genetics, if somebody has a GLP receptor mutation, a serotonin reuptake receptor mutation, a tryptophan transporter mutation, it's going to manifest, the symptoms are going to manifest very similarly, if not the exact same as an individual who has these environmental components that are going wrong. And here's the kind of the piece that I think a lot of people miss the boat on in functional medicine. And this is what I'm just kind of calling neurobiochemistry, which is like the body's wiring. And in the data, it suggests that between 60 and 80% of our patient population have some kind of history of trauma, sometimes complex trauma, which means that when their bodies are forming, they're forming under fight or flight, which means that they essentially get primed for an exaggerated response to pain and an exaggerated immunological response. So it also can manifest as these symptoms of gut and brain. And we don't really have a great way of piecing out which of these, and in many cases, it's a combination of all three. So I just want to sort of start by talking about that because I want to have a conversation around, how we can, as a medical community, how we can best serve our patients and what we maybe can do to try to unpack, certainly the environmental factors, but also kind of taking a look under the hood, particularly if you're not getting the results that you had hoped by doing some of those basics. You might want to take a look to see, hey, is there something going on with the neurobiochemical wiring here? Because a lot of times that's there. So you can clean up the gut all day long, but again, if there's a genetic mutation or if there's a wiring problem, that's a lot tougher to unpack, but definitely a conversation worth having, I think. Okay, so one of the things that, so when we talk about gut-brain connection, when we talk about data and studies, et cetera, we have a lot of different areas and a lot of different domains where the gut and the brain can talk to each other. And some of these we kind of know about, and some of them are a little less known. So we're probably all of us familiar with the vagus nerve, which is part of the parasympathetic system. It's a direct link from the gut to the brain. And when people have an upregulated sympathetic nervous system, sometimes the vagus nerve doesn't work so well. It doesn't communicate those signals very well. But they've done studies in mice where they've actually snipped this vagus nerve, and there were still some immunological differences that couldn't be accounted for based on just that one route being disconnected. We have, of course, the cytokines and inflammatory mediators that, if you have an inflamed gut, can also lead to an inflamed brain. Short chain fatty acids, SCFAs, stands for short chain fatty acids. I'm going to talk about this one quite a bit more in some subsequent slides. I feel like this is one of those key pieces that, again, a lot of people are missing. So the probably least understood are the neurotransmitters, and exactly how our microbiome influences these neurotransmitters is really just now starting to become unpacked. One of the myths, though, that I hear a lot is that people think that the microbiome is necessary for the production of these neurotransmitters in our guts. That's actually incorrect. Serotonin, of course, being the major neurotransmitter responsible for gastric motility, is produced all on its own without the microbiome. So, just exactly what's going on there and exactly how the gut influences those is really still being teased out. But we do know that the microbiome does influence the transporters, right? So again, when we're trying to piece out, hey, do we think that this is environmental or genetic? We need to kind of be thinking along those terms, right? Is this a transporter issue? Is this person not absorbing enough tryptophan? And is the reason why the microbiome, or could it be their genetics? So these are just a couple of things to think about. A lot of the studies that we have, as far as what's really kind of influencing the gut brain, come from germ-free mice, which survive. I would have thought that they died, but they don't. They live, but they live these strange lives. So we have these mice that have they're completely sterile, the mice are. And what we have found is that there's a decrease in their ability to recognize familiar faces. They have decreased memory. So kind of like a brain fog, type of a picture. They have a decrease in sociability. They don't really recognize known mice from other mice. They have a decrease in anxiety, which is interesting. You might think that's a good thing, but actually, when you're starting off in life, a little bit of anxiety actually helps prepare you later in life to respond appropriately to stressful situations. So if you're not having an anxiety response when you should, that actually is pathogenic as well. They have a decrease in this BDNF, which is brain-derived neurotrophic factor. That might sound familiar to you. That is a protein associated with neuroplasticity. So we know that the microbiome influences these domains in a negative way, but then there are these other things that are kind of increased in these mice. So 5-HT is serotonin. So they have an increase in the amount of serotonin that is available, which is kind of interesting. They have an increase in the cortisol stimulating hormone, so subsequently they have increases in cortisol. That checks out. Then they have these kind of almost OCD-like behaviors, so increases in locomotion and self-grooming. So we know then, based on mice, now we obviously can't ethically do this in humans, and exactly how this would play out in humans, we don't really know. But this is giving us a little good bit of insight into just exactly how much of a role our beneficial bacteria play in helping regulate these domains of neurocognitive behavior and health. So as far as human studies goes, we've got healthy and unhealthy subjects. One of the more compelling healthy subject study that I like to talk about is this one here, where we have these really cool brain studies where these individuals were either given a fermented milk product, right? So lactobacillus is what we're talking there, a control, so a milk product without being fermented, and then no intervention. And they were looking at what they call the rapid preconscious regulatory system. And so this is the system that's like whenever it increases when there's anxiety or when there's pain. And there, you can see from the images here, it's a complex network that works together and in concert. And so these individuals were given like anxiety producing images. And they very clearly demonstrated that the individuals who had this fermented milk product, the lactobacillus, had a decrease in this rapid preconscious regulatory system. So their body was not responding with as much anxiety and pain as the control or the no intervention group. So I really like this because it's just hard data. It's not really subjective the way symptoms can be sometimes, you know, and so I thought this was a really nice study. I like to talk about this one, but the truth is the overwhelming majority of studies that we have that look at gut-brain connection is in the kind of the inflammatory bowel disease patient population. So sometimes you see this referred to in the literature, as melancholic microbes, as kind of these researchers are trying to piece this together and try to figure out exactly what is going on here. Inflammatory bowel disease, just as a kind of a quick refresher, that's a quantity of life issue. Irritable bowel syndrome is a quality of life issue. So a lot of focus goes into the actual inflammatory bowel disease because these people have a shortened lifespan as a result of all the inflammation that they have in their gut. One of the 4 domains of health in patients with inflammatory bowel disease actually is related to their psychosocial component and how well they're tolerating this. And so depression and anxiety is actually now considered a component of the disease. So depression, anxiety, sort of schizophrenia, you name it, these poor patients that have all of this inflammation deal with a number of complex psychiatric issues on top of being very critically ill. And what I think is kind of interesting is that this actually goes both ways. So individuals who already have a pre-existing diagnosis of depression, anxiety, so forth, are actually at an increased risk of developing inflammatory bowel disease. And so this is where the data gets, I think, pretty compelling, pretty interesting when we kind of look at and unpack what we think might be the various things that are maybe contributing and why we think that's happening. Why is inflammation in the gut causing inflammation in the brain? What's really going on? Well, cytokines are kind of an obvious one because those are meant to travel throughout the entire body. They're meant to signal to the brain something's wrong. And so they obviously have been very, I shouldn't say obviously, but they have been very highly correlated with inflammatory bowel disease and subsequently depression and anxiety. And so is that the result of pathogens, or is that the result of an immune system that is already primed for fight or flight and is responding inappropriately to what are normally commensal opportunistic pathogens. The reason I talk about this is because that changes the game in terms of treatment. If a person has a true pathogenic overload, obviously we want to treat that. But if this individual is having an inappropriate immunological response to otherwise pretty benign pathogens that don't typically cause disease, killing those pathogens isn't really going to change their outcomes in the long run. It might in the short term. Another area that I think is super interesting and has been looked at quite a bit, and I would super encourage you to look at the literature where this is concerned, because I think it's really interesting and really compelling. But we look at the metabolization of tryptophan in these patients. And we look at how if you have an increase in inflammation, what ends up happening is your body will upregulate this enzyme called indolamine dioxygenase, IDO. Some of you may already be familiar with that. And that's the one that's responsible for taking tryptophan and converting it into quinolinic and kynurenic acids. Quinolinic, kynurenic acids kind of balance each other out. Kynurenic kind of slows down that inflammation. Quinolinic kind of speeds up the inflammation. But at the end of the day, if you have an increase in that enzyme, you have less tryptophan going to serotonin. So that actually is a really kind of interesting piece to all of this that has been found, is that lower levels of tryptophan, lower levels of serotonin in individuals who have increases in inflammation and increases in indolamine dioxygenase. The actual quinolinic acid itself influences our brain. So it's actually an NMDA receptor agonist. So glutamate receptor agonist, recall, that's the one that kind of keeps us going. That's the one that kind of fires us up, gets our brains going, gets our brains thinking. But too much of that is a bad thing because it becomes excitotoxic. And so these individuals are kind of what I term as wired but tired. They just really can't turn their brains off. They can't sleep, so they're tired all the time. And they're overwhelmed. Their whole system is overwhelmed. Another thing that's been demonstrated that I think is pretty interesting is this kind of vicious cycle that gets going when PLA2 starts getting produced. So PLA2 is called phospholipase A2, and that's in response to cell damage, in particular cell damage caused by arachidonic acid, which is obviously part of the inflammatory cascade. And what ends up happening is that PLA2 starts causing more inflammation, which starts causing more PLA2, which starts causing more inflammation. So these poor patients are on this vicious cycle of inflammation that's perpetuating itself. And it's actually been demonstrated specifically neurologically in the brain. So that arachidonic acid and PLA2 has been very much demonstrated as influencing our brain cells and is associated with inflammation in the gut as well. Another interesting thing that is true of our patients with inflammatory bowel disease is a reduced intake of tryptophan by the actual cells themselves. That's part of one of the reasons why my psychiatric patients, I almost always put them on an amino replete where we're going to be replenishing their tryptophan stores. That's one of the first things I do in almost all my psychiatric patients, because a lot of them have a reduced tryptophan uptake. Could be as a result of inflammation, could be as a result of genetics. We really don't know. If you have a genetic predisposition toward poor uptake of tryptophan, that could in fact predispose you to having inflammatory bowel disease. So exactly what's going on there, we still need a little bit more information, but we do know that much. And then of course there's the reduction of key nutrients, not just tryptophan, but I mean, you name it, just about everything has the potential to be decreased when you have profound inflammation occurring. So I don't want to spend too terribly much time talking about the bad juju that the bad bugs produce. I actually think it's a little bit more important that we talk about the good juju that the good bugs produce, but there are a couple of things that I think are very much worth mentioning. One of them is the phenolic compounds that are produced by certain species of Clostridia. And that's because they are structurally similar to dopamine, and they essentially fit where dopamine fits. And so if you've got this floating around in the human body, you're going to have a hard time correcting any psychiatric abnormalities as long as that's influencing the dopamine receptors in the brain and in the body. And in fact, influencing the conversion of dopamine into epinephrine and norepinephrine, another super important neurotransmitter for emotional health and energy. So not only does it interfere with the actual enzyme itself, but I kind of talk a little bit here about how it competes with the aromatic amino acid receptors, right? So kind of, are we able to just transport those amino acids across the cell? Not really well if we have these phenolic compounds in the way, kind of throwing elbows, so to speak. So, kind of checking that out, particularly in your patients who have a sudden onset of new symptoms. Maybe you've had them controlled for a while and all of a sudden anxiety is kicking up and their gut issues are kicking up kind of out of nowhere. Or maybe you've tried them on a lot of different therapies or medications or things like that, and they're just resistant to all of it. This might be something to be on your radar. So I like to screen as many people as possible for it with psychiatric issues, honestly, especially kids. I wanted to talk to you just a minute about gliotoxin, since mold is in the zeitgeist right now and something that's on a lot of people's minds. Gliotoxin is the one and only toxin that we can really point to that's very affirmatively associated with an actual colonization of Aspergillus species, and then maybe in some cases also Candida. A lot of toxins that we measure can't actually be produced at the temperature of the human body. But this is one that we know is actually part of the virulence of the species when it is growing in the human body. And the reason I say this is because a lot of people are kind of going toward this idea of potentially like mold colonization. And the truth of the matter is we don't actually know how much Aspergillus and Penicillium are in fact commensal to our guts, or how much of that is actually expected to be there and maybe is just transient, kind of moving its way through, but not necessarily causing any harm. The temperature of the human body, 98 degrees is a pretty unfavorable environment for a lot of mold species, and it's very unfavorable for the production of a lot of toxins. But what these toxins do is that they suppress the immune system. So individuals who are responding well to antifungals might be responding to an overgrowth of Candida, for example, as a result of toxins causing the immune system to be suppressed. So I think this is one of those things I just wanted to mention because I think it's important information for us all to consider when we're trying to unpack what's really happening with our patients. And I wanted to point out that the gliotoxin and the Aspergillus species, if they are overgrown, can suppress mast cell activation. So if you're thinking that this individual has an increased immunological response, if you're seeing a big, huge cytokine storm, then maybe we're not actually thinking in terms of a mold overgrowth per se. Could it be related to other environmental toxins? Sure. Could it be related to the fact that there's just an antigen in their environment that's stimulating their immune system? Sure. But if we're thinking about like the actual logistic kind of boots on the ground, a lot of these toxins are suppressing the immune system. So if they're just getting sick every which way, and you're like every time you turn around they're getting sick, that might be a little bit more of a clue to kind of tune this into, particularly to gliotoxin. It does cause gut barrier dysfunction. I put that in there to say that if you're thinking about giving nystatin to a patient who has gliotoxin, maybe think again, because nystatin should not be systemically absorbed. The liver can't tolerate it. So it's supposed to stay in the gut. But if you have a gut barrier dysfunction or a breach, and that nystatin gets out into circulation, you're going to cause profound liver issues in those patients. So maybe thinking about, even though, you know, they are themselves hard on the liver too, using some of those azoles that are at least designed to be used systemically, and we can kind of keep an eye on the liver enzymes. So I put that in there for that reason, and also wanted to share that patients with zinc deficiencies have a much higher likelihood of ultimately having a pathogen with this that's producing this gliotoxin. So checking zinc status, I like to check mineral status on almost all of my patients right out of the gate, and get those things corrected as quickly as possible. But the thing I really kind of want to drive home more than anything is just how important our beneficial bacteria are. I think that a lot of times in the functional side of things, I find that practitioners get a little kill happy, and I think that they get a little bit overly focused and overly zealous about bringing down pathogens, which again, maybe there's a time and a place for that, but a lot of times it's an immune system that is overreacting. And so killing pathogens isn't really the key. But if we can optimize our beneficial bacteria, a lot of times we can start to bring the Th1 and Th2 into better balance. And we can actually help their body to have an appropriate immune response instead of constantly inflaming their body. So really looking at those things that optimize beneficial bacteria, I put increased fiber in all caps because that's their favorite food. And as a result, the food that they give us is really important, right? So when they get fiber, they make short chain fatty acids, and that's the #1 energy source of our colonic sites, so our cells in our colon. Organic foods, of course, goes without saying. You don't want to be putting an antibiotic into the body. And fermented foods, if tolerated, certainly people who have histamine intolerance issues can't do those things readily in the beginning, but oftentimes we can get them to a place where they can when they are given the right supports. So we kind of already talked about this. These beneficial bacteria are associated with improved mood, a decrease in histamine production, and an interestingly enhanced estrogen production in women. One of the things, since we're on the kind of the topic of mold, though, I want to talk about is the judicious use of binders. So binders are obviously being heavily used by a lot of people in the industry right now. Detoxification is kind of the #1 thing that I think a lot of practitioners go to in an attempt to try to help bring down overall inflammation. And I think that there's some good reason for that. But I want to be kind of clear about the fact that if you're giving a person a whole lot of charcoal, yeah, it's going to bind some toxins, but it also increases inflammation. It slows gastric motility. It makes them more likely to have opportunistic pathogen in the upper GI if you're slowing their gastric motility. Whereas the fulvic and humic acids, they bind toxins as well, but they actually reduce inflammation and promote healthy gut flora. So I think those are really nice binders. Those are the ones that I tend to recommend to people the most. Zeolite does bind to toxins. You do have to be careful to get a very pure form, but it's an antioxidant and is pretty good at promoting gut health. Cholestyramine, of course, is a really strong bile acid sequestrant, which bile acid is where a lot of our toxins are stored. That's why we're using it. But bile acid is something that the beneficial bacteria need and love. So when we're taking that away from them, we're taking away their food. And we're making it kind of hard on the person's liver to be able to ultimately kind of make more. So be aware that if you're going to use that really strong binder, you probably want to reintroduce some bile acids. TUDCA, which stands for taurouracil-deoxycholic acid. It actually reduces neuroinflammation. So these bile acids, while they're carrying out toxins and we're kind of targeting them as a means of ultimately eliminating fat-soluble toxins, these bile acids are really important for brain health. So if our end goal is to make a healthy functioning individual who has a healthy functioning gut and to reduce their neuroinflammation, stealing away their bile acid can actually be one of the things that decreases their ability to reduce neuroinflammation. So thinking about replacing bile acid, particularly if you're going through a detoxification process with your patients and kind of stealing their bile acid, that's something to think about. But I really want to spend some time talking about butyrate and short chain fatty acids because I feel like this is where a lot of practitioners miss the mark. So butyrate in particular is very well studied, but so are all of the short chain fatty acids, but butyrate's kind of the one that we point to as being heavily associated with a reduction in neuroinflammation and heavily associated with a reduction in gastroinflammation. So it ultimately, there are these various G-coupled protein receptors that are in all over the body, and depending on where they're at, they influence us in various ways. And butyrate plays a really important role in activating those. So making sure that plenty of these short chain fatty acids are available for our system to be able to talk to itself, essentially, right? So where does butyrate come from? It comes from soluble fibers. So not insoluble fibers, not the kind that you get from fruits and veggies, soluble fibers, the kind that you get from grains and beans. Right? So that's like, I can't tell you how many people in the functional medicine community, the first thing they do is take away grains from a person's diet. They straight up are taking all their butyrate away. First thing they're doing, right? So not healthy and not something that we want to do for long term. Not only is butyrate involved with kind of the cell signaling, we talked about how it's the primary source of fuel of colonocytes, right? So it's between 70 and 80% of how they get their energy is from butyrate and short chain fatty acids. So we're making it impossible for gut cells to perform their needed function if we're not giving butyrate, if we're not getting butyrate, if we're not giving our patients soluble fibers. There's some interesting data around it being a histone deacetylase inhibitor, and it's kind of believed to be why this butyrate is associated with improved memory and improved remyelination in your patients who have myelination diseases. It's very much involved with enhancing our blood-brain barrier function, and actually increase that serotonin production as well into the inner chromaffin cells. So I just can't say enough good things about butyrate and short chain fatty acid. Butyrate is predominantly produced by the Firmicutes family of bacteria. So it's kind of, we have the Firmicutes and the Bacteroides are kind of the dominant phyla. And so it's really the Firmicutes that is highly responsible for our butyrate production. So again, just kind of thinking in terms of enhancing that as much as possible. So enhancing our beneficial bacteria and then subsequently the short chain fatty acids. And so I'm going to talk a minute about diet. I'm going to talk a minute about soluble fibers and why I think that restricting carbohydrates is not the answer. And there's actually a lot of data in favor of this, right? So if you really unpack like the healthiest colons in the world, they're in places where there's actually a lot of grain. There's a lot, so in Africa, there's a lot of corn, and in Asia, there's a lot of rice. And those are the healthiest colons as far as demographically that we have, really good data in support of. So, should we get rid of inflammatory foods? Are certain patients really sensitive to gluten, and do they need to experiment with potentially removing something like that? Sure, yeah, but we really need to be thinking in terms of what are we going to replace that with, and what type of soluble fiber can we get into that person. A lot of patients who have been on grain-free diets, I have found it very challenging to reintroduce grains because their microbiome is not used to it, their body is not used to it, not surprisingly, because the cells are starving, they're literally starving. So we've got to kind of reintroduce them slowly. So what I do is I kind of start patients on really small soluble fibers like guar gum, super cheap, super easy to come by. It's a thickener, generally very well tolerated. I don't think I've ever had a patient not tolerate guar gum. And then kind of a little bit bigger is kind of your citrus pectins, right? And then from there, when they're tolerating that, then the galactomannins, and then you can kind of get into the bigger fibers like the psyllium and the inulins, right? So in the patients who have already been really restricted for a long time, if you're looking to reintroduce these things, there's a way that you can go about it that introduces the smaller ones first. It's kind of like working a muscle. You know, if you have an atrophied muscle, the thing that's going to feel the best is not to work that muscle. The thing that's going to feel the best is leaving it alone, right? But the thing that is the healthiest for it is to work it out and to strengthen it. So that's kind of how I approach this with my patients, and I try to explain it in those terms to them so they understand that, yeah, you're going to experience little bits of discomfort along the way. We're really just working on, and you've got to kind of use your judgment on how much discomfort is too much. We've got to slowly start to reintroduce these things if we're going to have a healthy gut, if we're going to strengthen that muscle, so to speak. The other thing, you know, when we talked about in the beginning, how our patient population, a lot of them have trauma. I've seen a lot of functional medicine practitioners really support a kind of almost a disordered eating in these patients, kind of an orthorexia type of a picture that is particularly unhealthy. So I want us to be aware that these patients are already kind of predisposed to disordered eating and orthorexia. So we don't want to focus on removing foods. We want to maybe focus on replacing foods some of the time. But we want to be thinking in terms of replaces as opposed to remove. So that's what I've got for now. Hopefully you learned something new. If anybody has any questions, I'm happy to answer them. But yeah, that's what I've got for you today. You see any questions, Matt? I don't think I have the chat on my end. Maybe I do. Let's see.
I do not see any questions.
Okay. Good deal. Good deal.
Well, thanks again, Jessica.
You're welcome. Did you have any questions, Matt?
I don't have. I'm going to watch it a couple more times because there was so much information there. I'm going to have some good questions for you when I see you give this talk in Seattle.
Awesome. I can't wait.
I'm going to have to work. I'm going to have to like think some real hard on this one because
yeah, it's a little bit of a paradigm shift. It's a little bit different than I think what a lot of people are kind of used to hearing. So
yeah. Well, thank you again for giving this talk. I really appreciate it. And if people want to get in touch with you, what's the best way of doing that?
That's a good question. Probably via email, which is just my first and last name, Jessica Perley, and then NP for nurse practitioner, all one word, @gmail.com.
Awesome. Well, thank you so much.
You're welcome. Good to see you. I'll talk to you soon.
Yep. Bye-bye, everybody.